Gynae. I'm currently ST3 in Obs and Gynae in the West Midlands, currently at Heartlands Hospital. But I'll be going to ST4 in August, inshallah. And Nadira is also presenting with me. Do you want to start, Nadira? And then I'll continue after.
Yes, Assalamu alaikum everybody. My name is Nadira. I'm also an Obs and Gynae trainee. I'm ST2 currently in Coventry. And we're very happy to be presented to you guys. Can everybody see my screen? Can people see my screen?
Yeah, I can see from my end.
Okay, halas, then I'll just start. Okay, so obviously this talk is on all things Obs and Gynae related. If you guys have any questions, you guys can put it in the chat box, as well as the fact that later on we'll have a whole session for that, inshallah. So let me just try to... Okay, contents. We'll be speaking a bit about us, although we've spoken about that, about ONG training, person specifications, timeline, the application, the MSRA, interviews and scorings, and role of an ONG doctor, as well as day in the life, and inshallah, the Q&A session. So a bit about us, like Ladan said, speaking about me, I basically trained in China and then worked as a junior clinical fellow in medicine for 2.5 years after I did the PLAB path, and then alhamdulillah matched into training, and currently ST2 heading into Reg year in a month or so, inshallah. And Ladan, you can mention a bit about yourself.
Yeah, okay. So I studied in China as well, in Beijing. And that's where I met Nadira initially. And then I did my 6 years of training there, including internship. And then I applied to do my PLAB in the UK. And then once I did my PLABs, I did a foundation year 1, but it was non-training. And then I got into a training F2 post. And then while I was doing my F2, I applied for Obs and Gynae. Now I'm in and going on to ST4, inshallah, in August.
Okay.
Yeah.
So in regards to Obs and Gynae training, I'm going to go straight into the person specifications. First of all, Obs and Gynae is a very rewarding career, alhamdulillah. It is stressful in its own ways, but there's benefits to everything. In regards to when you're applying for training, you always have to look at the person specification. The reason this is essential is, as a medical these are some of the things that you need to be looking out for early on, so that you can make your tailor your basically CV towards that. So they look at qualifications, teaching experience. Teaching can be in anything. It doesn't necessarily have to be Obs and Gynae related, but you need to make sure that you have some evidence towards that. So feedback is good. Certificates would be good, because later on you can speak about that in your interview. Research and audits, again, it doesn't necessarily have to be Obs and Gynae related. Obviously, if it is, it gives you more things to talk about during your interview, but make sure that you have things to tick off when it comes to research and audits. Commitment to specialty, I'll speak more about that later on, but that's one thing that's very important. And personal skills, including communication, management, and leadership skills. And the way you need to show that is through examples. A lot of the times you need to use anecdotal, measures to kind of mention how you've gone about showing those skills. So this is more about the commitment to specialty that some of us have done, or we can use examples of. So in medical school, for example, your ONG placement, an insight about how you felt about Obs and Gynae. If you're someone who's done electives in the past, you can kind of mention that. I personally did electives in Kenya. That's actually where I fell in love with Obs and Gynae. Did 4 weeks, so I was able to speak about that in my interview. There's a RCOG Medical Student Day that usually is around June on the RCOG website. So it's something that you can speak about during your interview and later on get points for. If you've done an F2 rotation, a taster week, if you're international, if you've done your internship abroad, if you had an ONG block, that's another place where you can kind of mention experience. In regards to audit, if you've done an obs and gynae audit, that's somewhere where you can also, again, show commitment to specialty. I think London can speak more about outreach in the Somali community or things that you've done that can show ways that you show commitment to specialty.
Yeah. So for community outreach and things like that, what I did, for example, was me and another surgical trainee, as well as an anesthetist and a GP, we did like outreach program. So we went to different masjids around the UK, in a few different areas, and we kind of discussed about cervical screening and like if you have women who have postmenopausal bleeding, what to look out for, all the risk factors involved, and then it was really good. They really enjoyed it. And I also went to, when I was a medical student, I went to Somalia and I did some type of like an observership while I was there in obs and gynae and pediatrics. And it was really a good way to kind of see about the pros and cons in developing countries and what they're in more need of, which was good because Somalia is a very the RCOG mentioned that they have the highest maternal mortality rates in the world. So it's a good place to kind of go and see. And then it also was good when I was in my interview, I mentioned that. So they really they enjoyed that part. They had a lot of questions. So it's good to kind of add that. Another thing to add for your to show commitment to specialty is you can do your part one exam. A lot of people have done that. I haven't, but when I started my training, I've noticed some people who did their exam. So does give you ticks off
Yeah.
a part of the interview process. So that's something that can be done.
Yeah. Yeah, that's true. Part one is a good way of showing commitment. So yeah, that's some of the examples that we've mentioned. Then moving on to, sorry. Yes, so a timeline. This is the timeline I used from 2022 intake, but that's when I was applying. But when you want to find out the timeline for any specialty, you obviously have to go through Health Education England, and they have a website in regards to specialties and the timelines. With obs and gynae, there's usually one intake, and that's the intake is in August of every year. And the advert is usually placed in November. So you have to have an Oriole account to kind of apply in the first place. It's called what is it, the recruitment when they do the first part, and then they have a second round sometimes. So this year, they had a second recruitment that opened up, and this was, last year, they had a second recruitment that opened up for people to start in February. It's very rare that does happen. The majority of intake is in the August intake, but sometimes if there's places left over or if they want to recruit more people, they might sometimes have recruitments that open as a second round. But the main round that you need to worry about is this one. That's usually the August intake. So advert is usually placed around November. Then you have like a month to do your application. Once the application is done, which I'll go further into detail, they have a long listing process. In between that, they have something called the MSRA exam again that I will speak about. That MSRA exam, once you've done it, is when they send out the interviews, because depending on what your MSRA score is, that will give you an interview or not, depending on what your score is. And if you can see from here, from the interview window, they will ask you to go on your Oriole website and book the interview, do the interview, and then offers are released. And then you have something called the hold deadline and an upgrade deadline, which is basically if you get an offer, you can hold that offer if you didn't get your first choice and wait to get the offer that you need if you get it. If not, you might have to just accept that one. So yeah, and then the anticipated start date for each one is usually the first Wednesday of August. But that's just a rough outline of the recruitment timetable. Then, like I said, Oriole is the website that you need to have an account for all specialties. Obs and Gynae is actually pretty straightforward application, I would say, in the sense that you would need to put your personal details. You complete your history in terms of your employment history or, you know, any experience that you've had. You do need to have your request form signed, this is for any international graduates. I think with the foundation program, they just have their, is that the certificate? Is that them? Basically your competencies, I think, for the foundation program. I'm not really.
Crest form. I think it's called the crest form.
Oh, do they have that for the? Okay, yeah. So basically, either you've shown that you've done your foundation program or the quest form to show that you meet the requirements. And then something to note is that if you have more than 24 months of experience in obs and gynae, you would not be eligible to apply for ST1. You'd be eligible to apply for ST3. So you have to be very careful of someone who's practicing abroad that you don't pass that 24 months if you want to start off with ST1. And the advantage to starting with ST1 is the fact that there's more placements, like places for ST1, and ST3 is more competitive because there's less places for people to start, just to let everybody know. And then this is in regards to the MSRA. Then should I speak about MSRA or you'll do the clinical part?
Yeah, you can talk about
Okay.
this. I'm sorry.
So MSRA, if you guys know, it's called it's the multi-specialty recruitment assessment exam. This is used for a lot of specialties, like GP, psych, and obs and gynae being one of them. It basically consists of two papers. There's a professional dilemma, like a SJT aspect, and a clinical problem solving aspect. This is a multiple choice exam. So once you book this exam, it's a free exam. You just book it. Once you do your Oriel account, then you'll be sent a link to set up a Pearson account. And that's how you book your MSRA. It can be done basically anywhere. It can even be done, I think, from abroad, depending if they have those Pearson centers. And the importance of the MSRA is basically it's a filtering system that's used to kind of determine if you're going to get an interview or not. So the higher you score, the better chances that you will get to the interview stage, which is a good sign. And it does hold a good weight. So 1/3 of your overall score will be based on your MSRA score. So once you get through that, then also it will, you know, have importance later on. So it is very good to work hard on the MSRA and try to get the best score that you can. I think, I don't know if they've done it this round, but I know for the last 2 rounds, the people who've gotten like the highest, like the first 75 people who've had the highest score were bypassed, meaning they didn't have to do the interview. So if that's another advantage, so you would then just rank your jobs and then hopefully get your first pick. So again, I would you know, stress the importance of trying to get a very good MSRA score. And yes, it counts for 1/3 towards your overall score later on, and that is going to help determine again your rank, and your rank will determine how likely you are to get where you want to go. So moving on, this is the interview part. I'll let Ladan speak about that a bit more.
Okay, so this is about interview, so clinical prioritization. I actually have mine that I saved back when I did my interview for the job. So first, they asked different questions. For example, like they had the portfolio section, priority station, and a communication station. They asked about like why did you want to go into obs and gynae? So everybody has their own reason why, but mainly it's they asked that question. What commitments have you shown to the specialty that we explained before? For example, for me, what I said was I went to Somalia, actually did some observership in obstetrics and gynecology there, and I talked about the interesting cases that I've seen while I was there. They ask, what do you know about the training program? Team working skills, what have you done that shows that you have leadership skills? You can give an example as well. They ask what you're most proud of. Have you done any teaching? They ask about interesting audits that you've done. It's good to have one in obs and gynae, then you can kind of discuss about your findings. They really give points for research. And if you know, if you feel that research is important, especially in obs and gynae, and should every clinician do research? They ask also why you should, why did you want to choose, sorry, why should you choose you as a trainee? So you can talk about your strengths and your weaknesses, and make what makes you a good teacher in the specialty. Quality improvement projects are really good as well, on top of your audits. So if you have any quality improvement projects in your department, if you're in F1 or F2 or you're in a clinical attachment, please get involved with those. And they also ask about, yeah, quality, what is quality improvement if you haven't done a quality improvement project. Yeah, those are the main things that they ask in the structured interview. So those are the main domains. They also had a part for a priority station where they asked a few different medical conditions of different patients, and they asked how would you prioritize, for example, if you are on call, how would you prioritize them? How would you get other people in the staff of your staff to kind of help out? So that was one of the stations, and they had a communication station as well. So they'll either have an angry patient or a patient who's upset about their findings or breaking bad news. So they really look at how you perform in that station, and you get marks for that. So those are the main that was the main interview and how it went. So this part talks about, yeah, clinical prioritization, structured interview, global performance, and then they give you a total score of how you performed compared to everyone else. Yeah, so if you could change the slide, Nadir. Yeah, this is the prioritization. I talked about this part.
Okay. Yeah. So yeah, this was just an example. There's obviously if you go online, you'll be able to find a bit more. But Ladan kind of spoke about what she went through, and then I will just click into yes. So this is in terms of the shortlisting. So I think once you've done the interview, like Ladan said, there's a structured part, that the clinical prioritization part, and then add the MSRA on top, then that is how they basically come up with your overall score. The global judgment part is basically just how they feel about you based on how you did your interview skills. It's very subjective, I would say, to be honest, but as long as you're enthusiastic, usually they do score you well. Once you've done the interview, they will open up rankings for you. So ranking basically meaning all the deaneries are there, all the hospitals, and then it's a task in of itself. You'll know also the amount of vacancies for each deanery. And then based on that, you rank. Then when the offer date comes, they will offer you. And this is what I was talking about when I say you can hold an offer. So for example, I got my 6th placement initially, so I held that offer, and then they basically reshuffle and recycle the offers because someone else might want something else. Long story short, I got upgraded to my first choice, and then once you get your choice, you just basically accept the offer. Obs and Gynae, in terms of competition ratio, so it was 3.37, so 1 in 3 chances, basically. It is pretty competitive, and I think usually, like when I was doing it, there was 240 placements. Sometimes they add a bit more towards the end, but roughly that's usually what the number is. And yeah, there was 877 people who applied. They filter again through the MSRA. But yeah, so it's really good to try to work on the things that you want if you are interested in Obs and Gynae to make your CV more competitive. So role of an ONG doctor. Ladan.
Yeah, so this is the interesting part, role of Obs and Gynae doctor trainee. So as you guys know, it's a specialty that has both medicine and surgery. So that's the fun part of it. You work with women and young babies in utero. So it provides care to women and their unborn child, and you look after women's sexual and reproductive health all throughout, from young age all the way to older ages in gynecology. You work closely with other medical disciplinary teams such as anesthetics, theater, midwives, nurses, the neonatal team. So you see all of a range of that. In obstetrics, there are different clinics So there's the antenatal clinic, there's maternal medicine where you work with other specialists such as endocrinology, cardiology, neurologists, hematologists. So you'll be in clinic and they'll also be running alongside you. So you can kind of ask for their opinion in regards to that medical condition throughout the pregnancy. There's also a fetal medicine clinics where they do a lot of scanning and diagnose conditions in utero. There's elective section lists. There's a postnatal ward that usually the SHOs cover, and if they have any concerns, they'll escalate to senior registrars or junior registrars. There are obstetric labor ward on calls where you come on to labor ward, you take the handover, and then you join your team and you do the ward rounds with the patients on labor ward. And then you kind of monitor them throughout the whole process of labor. Usually the midwives in this country, which is really interesting, the midwives in this country, they do all the low risk deliveries, and we only come in when there is a complication, whereas compared to other parts of the world, like North America especially, the obstetricians deliver all the babies. So that's kind of what's different here. So you only get involved if there needs to be an instrumental delivery, if you need to kind of monitor the woman holistically, as in looking at her CTG, which is the monitoring the baby's fetal heart rate. If you need to kind of, if there's any medical issues that are come about for the
Sepsis
woman
or
in
yeah.
labor. Yeah, if you need to kind of escalate to go ahead with a cesarean section, then so you make those decisions based on, and you'll gain these skills as you get your experience. Then in gynecology, there's outpatient clinics. There's the 2-week wait clinic, which is usually for cancer patients, and then there's the benign gynae, which is like women who have fibroids, who have cysts, who need following up. There's scanning also in gynae, early pregnancy scanning, as well as scanning to check for fibroid cysts, all of that. There are gynae oncology clinics, which is a subspecialty in gynae. We don't really go to those clinics, but if you're interested in gynae oncology or you want to kind of do a subspecialty, that you can attend those clinics. There's hysteroscopy clinics where they do smears, insert coils in those clinics. They also do that in theater too, if the patient's not able to tolerate it in clinic. And then there's the major cases that need laparoscopy, laparotomies, things like that. They're pretty interesting cases. Sometimes they even have a robotic theaters that's kind of new, that's been ongoing lately. Then they have sometimes the SHO does cover gynae oncology in some hospitals. So out of hours they will cover, and if they have concerns, they'll can raise it with the oncology team. And then there's gynecology on calls, which is you see the wards, you go to A&E. When patients are admitted from there, you can clerk them and then see them on the ward. So that's mainly obs and gynae. There are different subspecialties that are pretty interesting. There's a so like for obstetrics, there's fetal medicine, maternal medicine, and then there's, I think those are the main ones for obstetrics, and then gynae, there's pediatric and adolescent gynae, which is very interesting. You can see like Turner syndrome and these really interesting cases like heavy menstrual bleeding for young yeah. And then there's the gynae oncology, and then there's benign gynae. Those are the main domains, subspecialties where, and then when you're doing your ATSM, which is the advanced training module, you can divide from your training and kind of see which subspecialty you would like to do. Yeah. Then go to the next slide, Nadira.
So this is
Yeah, so we can. Yeah, this is the weekend of life. So yeah, normal working hours, they usually start at 8 and they end at 5. Some places start at 8:30 and end at 4:30. So it depends on the department. And on
some places
calls are
start
like
8 and finish 6, like mine.
yes, so they're different. But
Yeah.
then they have more off days.
Yeah.
So and then your on-calls, there's twilight on-calls. They're from 5 to 9 or 5 to 8. And then you have your nights, which is the same from 8 till 8 a.m. So a normal day, what kind of made me gear towards obs and gynae is every day is different. You're never doing the same thing, such as like in medicine or other specialties. So you could have a morning where you have elective sections in the morning. In the afternoon, you're seeing your patients on triage, or you're seeing your patients on the ward, or you might even just see your patients post-op. And then let's say another day you have a full day of just antenatal clinic, or another day you have a full day of gynae theaters or gynae outpatient going into different specialties. Or you'll have a day, afternoon or morning of teaching, where you have we have departmental teaching where either you will do the teaching, or another trainee will be doing the teaching, and it's overrun by a consultant. So it is continued learning. And we do have our days where we can do we have focused learning on that day. You can do your own thing, or you can either go to the clinics that you like or that you're interested in, or you can do your own learning, which if you have an exam, you can do your own studies, and so on. So that's your more of a weekend in the life of an obs and gynae trainee.
Yeah. So just to add a bit on that, same thing with London, like I think with obs and gynae, it's very diverse. There's so much variety. No 2 weeks are the same. From an SHO standpoint, it is very supportive. Well, it depends on where you are, but generally speaking, obs and gynae is a very senior-led also specialty. So you don't ever have to feel like, you have to make these decisions by yourself. When you're doing elective section lists, for example, on Monday and you're ST1 or ST2, you'll always have a senior clinician that's there to kind of see which cases they think might be appropriate for you to do, and teach you the skills based on that. If you're interested more towards a specific, like let's say for example, I wanted to get more exposure to menopause, I could find out what clinic is running, speak to the teams, the rota coordinator. Usually they're very helpful in kind of getting you into the clinics that you want to get into. That's one thing I really appreciated about obs and gynae, because I did medicine for a good while and I don't think I've ever done clinics, whereas here you're kind of scheduled into antenatal clinic, you're scheduled into gynae clinics. If you're tired of clinics, you can go to theater. So it is a very rewarding specialty in that regard. Yes, it is stressful. Me and Lillian will get into the pros and cons of things later, but it's something that if you feel like you're the kind of person you always want to kind of be stimulated, you'll definitely be stimulated. So yeah, that's more or less what it is. So I'm going to speak a bit more about what O&G training is, in terms of the training curriculum. So it's basically a 7-year program. You need to know this information because they will ask, they asked me in my interview, like, what do you know about obs and gynae training? And 7 years is not enough for you to say. You have to know the stages. So ST1, ST2 is considered your basic years. You're an SHO, and then you move. So by ST1, ST2, you are expected to do your Part 1 exam in order to move on to the intermediate training, which is basically your reg years. Well, the rest is reg years, but to get into registrar level, you do SC3, 4, and 5, and then are expected to do the Part 2 and Part 3 exam within that time in order to move on to the advanced training aspect, which is the last 2 years. Which is SC6 and SC7. So they used to do something called ATSMs, which basically you kind of chose specific, like Ladan said before, for example, if you're interested more in benign gynae or you want more obstetrics, so maybe labor ward, they had specific blocks that you could choose to kind of do. They have this year introduced new things to the curriculum called SITMs, which is more basically you can start earlier, like around ST5, to start choosing what you kind of want to do and start working towards that competency. We both are not fully well read on that because they're trying to introduce it now. The RCOG is bringing out more towards the curriculum and how that's going to be achieved, but it is, I think there's good in it in the sense that you can start, let's say, you kind of don't want gynae, you want more obstetrics, start, gearing yourself towards that at an earlier time. So from ST5, before you would only have to be able to do it from ST6, but ST5 now you can start a bit earlier. So the more we learn about it, then we'll hopefully be able to give you guys more advice. But the RCOG is giving advice and guidelines on how to like get into more towards that curriculum. But for now, the basics haven't changed. So 7 years, 3 exams, and yeah. Anything you want to add, Ladan?
Yeah. So as I said, like the part one, if you've done it before,
Yeah.
you got into training, then you can just kind of focus on your first ST1 and ST2. You can focus on your procedures and getting things signed off. And then by the time you do intermediate training, ST3 to ST5, by ST5, you have to have had your part 3 exam done. And then ST6 and 7, you just focus on your specialty training, which is very full on. You kind of have to get a lot of procedures signed off, especially if you're doing like obstetrics, high risk obstetrics labor ward. You kind of have to get a lot of things signed off. For example, breech vaginal delivery, which we rarely see in obs and gynae. But yeah, you have to get those kind of rare procedures signed off. So it's good to have all your exams out of the way and then kind of focus on your training. What's good about obs and gynae is it's a run-through program, so you don't have to kind of reapply like in other specialties, which is great. So there's different SIPs, which is sorry, what was this one
Oh yeah,
called?
I got it back. Sorry.
Curricular progressions, yeah. So ST1 is more about observing and kind of getting slowly getting into getting procedures not signed off, but like learning how to do them. The only procedure that you have to have done is the cervical smear. So it's pretty easy the first year, yeah. And then ST2 is, I think, very difficult, right? It was very for Nadira to get kind of get everything signed off. I remember it was a full-on year for me. The last part of my training year, I was still struggling to get instrumental deliveries and things done because there's a whole lot. You have to get your basics. You have to be able to do a basic cesarean section. So like on a primip, first woman who's been pregnant for the first time, instrumental deliveries like ventouse and forceps, repairing the perineum after an episiotomy or a tear, and then surgical management of miscarriages and terminations, and then insertions of the coil, and then you have to do an endometrial biopsy, and then you have to do your exam as well. So
And
there's so many.
ST2 is a very stressful year of about to be done. But the main thing is, and in hindsight, like if there's anybody who gets into obs and gynae, hopefully there's going to be plenty. But as a ST1, if you can get these things done, I think there are so many opportunities where I could have gotten maybe my C-section signed off or the perineal repair, but I was just like, oh, I'm just ST1. I just want to learn stuff, But when ST2 comes and you have to do all these things and it's like, you need to get 3 of each. So it's not easy getting, like, I was still waiting for forceps up until like 2 months ago. So if there's anything that I would hone in is like, try to be very proactive, get these things signed off, especially when opportunities come up. Obs and gynae is, especially depending on which hospital you're in. Even with DGHs, you do get a lot of exposure. So yeah, it's ST2 is a crazy year, but we'll cross that bridge. Inshallah, when you get
I would advise DGHs because DGH there's less competition to get procedures. There's not that many trainees. Yeah. So when I was an ST1, I was working in a DGH, but Nadira was an ST1 in a very big unit. So yes, she learned more than I did, but I got to do more than I think.
hands-on wise, because there was more competition when I was doing it. And
Mm.
you would always feel like, oh, the ST2 probably needs it more than I do. Whereas if you're in a DGH, maybe there might not be ST2. So you get to do those hands-on skills and it really does help you later on. So that's, and this is not only relevant to ST2, it's like in every, year, whatever you can get, just try to, send those off. But yeah. So this was a rough idea of what the portfolio would require once you're in training. So we're expected, so these are OSATs. OSATs basically are specific hands-on procedures that you need to do. Then there's something, if you've done F1, F2, you might know, like reflections, mini kexes, case-based discussions. those are things that you would also need to get signed off. Knots is something, it's basically a, what, how would you explain a knot?
It's non-technical skills, so like your cognitive behavior, how you prioritize. They'll ask you, for example, let's say you've had a theater list. How would you prioritize these lists? For
Yes,
example, there's a woman who's a diabetic. She can't wait for 3 other cesarean sections to go before her because she's
diabetic,
fasted.
fasting, yeah.
Yeah, so you have to know how to prioritize them. If it's a busy labor ward, when do you tell the consultant to come and help you, or when do you involve your SHO to do certain procedures or things so that you can get other jobs, more emergency cases done. So they kind of ask how you work in a team, basically.
Yeah. So that's one of the things that we'll ask you. And then 202s are basically feedbacks, forms that you have to do. And then every year there's specific courses that are required for you to do or attend. And those are usually covered by the deanery. And yeah, so before we get to the helpful links, Ladan, I was thinking we could probably give some pros and cons about obs and gynae.
Yeah. One more thing I want to add about training, which is really cool, is they also have intermediate training course, which is, for example, you do your basic ultrasound training. You get it. You do like there's a course like a day or two that you do with the deanery, and then after that you kind of put that in practice throughout. So it's basic ultrasound scanning.
Scanning,
But
yeah.
then to continue, you can apply for intermediate scanning training, which every trainee can apply for, and then you'll do that for like a year. You'll be in, I think every week, twice a week, you have scan clinics where all you do is scan. So you get really good at scanning. I think as an obstetrician,
Scan,
it's
yeah.
good to have that as a skill. So you can do it in either gynae or obstetrics. So you choose, they're divided. Yeah, so. But yeah, we want to talk about the pros and cons as an obs and gynae trainee. So I think well, we could start with the pros. So the pros are um, it is a run-through program, which is really good. You don't have to reapply. As I said, like in other specialties, you have to apply once you do your core training. This is just run through. So if you get your exams done, you could easily progress to the next year. And then it's a specialty where especially in in obstetrics, women they're usually healthy women who are just going through a life change, basically. So they may there might be, like, for example, an emergency and the woman may be deteriorating, but once you deliver her and everything, she'll just recover so quickly. So you do see a very quick up and down in obstetrics. Yeah, it might be get very stressful throughout the day, but then it kind of eases out once baby is delivered and everybody's fine and resuscitated. Usually everything's women make a quick comeback. So that's really good. It's a very I think highly supportive specialty, like Nadira said. There's so many people to ask. Even consultants usually call other consultants for support. When things are like when they're not sure about something. So it's very encouraged. Yeah, in that sense. Yeah. Anything you want to add for pros?
And it is very gratifying, like delivering babies and all that.
Yeah.
I do enjoy it in that aspect. Even with things like with gynae, helping people like in regards to being there when it's a pro and a con actually, if I think about it in terms of like the emotional aspect, like sometimes you're there for people when their happiest moments, but sometimes their saddest moments. So yeah. Con wise, I think it can be a very stressful career in terms of like the decisions that you're making sometimes. I didn't have to make these decisions at this point, but I think the more senior you get, the more responsibility you have to pick up. I feel like um the decisions sometimes, especially the acuity of things, like it's like seconds sometimes or minutes that you have to spare in terms of like when it's like a bratty in this room and you have to run to clinic, theater, and etc. But obviously the highs are pretty good and the lows sometimes if you have a bad outcome, they could, it might be affecting a whole family. Like it is really sad. I think the just as an example, when I was at FT1, London was my registrar. And I think I had a case, I don't know if Mother remembers it, but we had a patient that we had to deal with that had a miscarriage. And I think she had a scan the day before that showed a heartbeat. And then basically at this point was, heavily bleeding. And the basically the she was bleeding, and we examined, and basically it was an inevitable miscarriage, but the parents couldn't believe it, and they both broke down, and I just got so emotional. I remember looking at Lothan, and Lothan was just like, yeah, Nidhi, you can step out, it's fine. Went out, and you ended up, I remember counseling them, but it was just a lot. And sometimes you will feel like that, but it's like I said, it's very supportive at Ladan. And I have, there's always someone to speak to when I have SHOs that sometimes see something that's very like, traumatic, and they're able to kind of speak to us about it. So the emotional wise, because I am a very sensitive person, it does get to you. And sometimes there's certain cases that stay with you, but then I think it also makes you a better doctor on how to counsel these patients and how to just be there for them. So it's a rewarding career. High stress.
Yeah, it makes you stronger, and you learn how to handle your emotions. As an ST1, I was always emotional. I was all over the place. So all the miscarriage, especially the recurrent miscarriages that come into gynae clinic, or they come into the department. It's very sad when you have to kind of counsel them. They'll just be like, "Oh, can I get a scan for it?" And it's an inevitable miscarriage, like
Yeah.
us is open and they're bleeding, but you still have to tell them, "Oh, we won't do a scan for you," because this is a miscarriage. And it's hard, yeah, breaking the bad news, but you learn, and it makes you a better clinician.
Yeah.
So that's one of the cons, yeah, in
And
training.
litigation aspect, I think that's one thing I was scared about. But not that I think it's inevitable that you will have sometimes a bad outcome, but again, you're doing it as a team. It's never
Yeah.
a blame game. It's only you. They will, the trust will support you. You have indemnity cover for a reason, and it's not like, everything just falls on you. It usually is a I would say not a team decision, and there is a way of kind of, speaking about these things. There's a lot of support in that regard. So it's
Mhm.
it's gonna happen, but just know that you will be supported. As far
Yeah, as long as you follow. Yeah,
as
as long as you follow the guidelines and you do what the evidence says to do, then you'll be fine. If anything happens and you do end up in court, then you just answer as in you've done what you had to do. So you can't control what's going to be inevitable, and things happen. So you just have to. Your team is there to support you if anything goes wrong, and there's duty of candor that you have with patients afterwards to help them explain about um, anything that's happened to them. So that can always help discussion, explaining to patients as they go along, everything that's happening. So that does help a lot in obstetrics, especially. Mm. Keeping patients involved. Mm.
So that's a quick summary of Zangani. It's a heavy topic, but these are some helpful links. So for the MSR revision, PassMed and eMedica were some of the sources I used, and I think were very helpful. Interview prep, you can speak to people, as well as the fact that there is that book that I've just put a picture of that kind of helped me, as well as doing mocks. That kind of also helps with interview prep. And there's a lot of information on the training and the exams, and helpful information on the Royal College of Obstetricians website. Me and Ladan are both happy for anybody to contact us with advice or questions. And from that, we can hopefully move on to the question and answers, and Samay can hopefully.
Just one thing I wanted to add about the interview prep. There was a course that I've done a course for the interview prep that was really good in London. So yeah, you can do courses. They really help with the interview process. But yeah, thank you.
Should I just give this to Samaya now so we can look at the questions?
Yeah, they can take over.
Can you hear me okay?
Yeah?
Yeah.
Yeah. Can you hear me okay? Can you guys hear me?
Yes, I can hear you.
Are you able to hear me?
Your video is frozen, but I can hear you.
You can hear me okay, right? Okay,
Yeah.
all right. Salam alaikum.
Walaikum
Oh, my
assalam.
video's frozen, is it?
Yeah, your video is frozen. It's okay.
Great. Okay. Is it still frozen?
Yeah, it's frozen for you, right, Nadira? Or is it
Yeah,
just
I
me?
can't even. Alhamdulillah.
1 second. 1 second. 1 second.
Okay.
Assalamu alaikum.
Alaikum salam.
Walaikum
Hello.
You're frozen again.
It's because she's abroad.
Because I would have done it, but I can't see the questions or if anybody.
Tell me when you can see me.
Yeah, we can see you.
You can see me
I
now?
see you, but you're frozen, frozen button.
Am I frozen?
It's okay, the voice is working.
Okay, so long as my voice is working. Okay, let's start the questions. The first question I have is, can you do an obs and gynae rotation as a foundation year 3 doctor?
Yeah.
You can. The thing is, not as a rotation, like for example, you could do like a junior clinical fellow job if that comes out as an obs and gynae
Okay.
doctor. I know that it's very tricky nowadays with the whole locum market, but I know people who pick up shifts. Sometimes there's blocks where, because a lot of people don't really do obs and gynae unless they have obs and gynae experience. So sometimes they have blocks. Like for example, in my hospital, they had a gap last year where someone was able to fill it as a locum doctor, but then was doing a full rota. Another thing you can do that I noticed someone do was, for example, you're in a hospital and you have a bit of obs and gynae experience, you can get in touch with the obs and gynae department and get into their locum. So once you get into their bank, then you can start picking up shifts slowly. And that way you could get experience that way, like come in. So that's another way that I think you can get experience. So it is possible as an F3, it's just that you have to be keen and find opportunities as maybe a trust grade, or even talk to agencies and figure out if there's ways you can get into their bank.
Okay, great. Another question I have is, how is the work-life balance?
Ladan, you can talk about that.
Work-life balance. Yeah. Work-life balance can be a bit tough. Like Aniga, I'm a mom. And yeah, it can be a bit tough because I work full-time. I do rely on my family to help a lot. But there are a lot of parents who work 60%, so they can spend some more time with the family. A lot of the trainees are also parents or married, so they do go part-time, but it is encouraged to have a family. They do encourage you in obs and gynae to grow your family, and they'll give you time off, and you get a full year of maternity leave, and so I think it's all right when it comes to that. But just like any other specialty, especially surgical specialty, it is a bit difficult with life balance, work-life balance. Yeah.
Okay, great, thank you. Another question is, so as an IMG who's completed training abroad, has done a 3 year master's program, would you recommend starting as ST1 or ST3?
Oh, it depends. A lot of people do apply as an ST3 that I've seen. But I would say kind of, yeah. Go ahead.
Because it depends, ST3, if you're going in, are you someone who has obs and gynae experience? Because research is different. If you have clinical obs and gynae experience, then you can start, you have the option of starting from ST3 if your experience is less than 24 months. However, if you don't have clinical obs and gynae experience, you can only technically apply for ST1, because you wouldn't show, because when you're applying for ST3, you have to show evidence of you having done, being competent in sections. Of course, a lot of countries don't practice like instrumentals, by the way, so sometimes that's the barrier, unless you have like you've done a trust grade job in obs and gynae in this country and then apply from that way. Wouldn't it be, Ladan?
Yeah, I think at least to do a trust grade job for a year and then apply. I've seen that.
If you want to do
people,
ST3.
yeah, from ST3, yeah. Mhm. Like there was a trainee, JST or something that worked with us, Nadira.
Yeah.
Fadi, I think he did a year of that, and he went on to do an
Then he
ST3.
applied
So
for
yeah,
ST3. But he
yeah,
had
he had a,
Obstetrics experience from his country, and
yeah,
he had whatever competency he had left. Like for example, the main one usually is the forceps and the ventouse deliveries. You can get that signed off as a trust grade and then apply for ST3 to kind of cut those 2 years if you want.
Mhm.
Great. I have a few more questions. By the way, am I still frozen? Just out of
No, 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 no,
curiosity.
no,
No,
no.
no,
Oh, I'm not frozen anymore. Okay, great. Okay, that's good. All right. Another question is somebody has said that they love obstetrics and gynecology, but also love GP.
no.
What would you advise with regards to achieving family life, work-life balance, etc.?
Go for what you love. I think obstetrics is a very fun specialty, especially if you love the specialty. You won't get tired of it. It's not a boring specialty. There's always something going on while you're working. Very interesting cases, very life-changing cases. So just like with other medicine. But I think you should go for obs and gynae. But if you want like you can always do GP with an interest in women's health.
Yes.
So that's quite good.
Yeah.
But you won't get that obs and gynae, like you won't do any of the like surgical part of the specialty. It will only be basically clinic. So it depends on what your interests are.
Fantastic. Amazing. Another question is somebody's asked if they were to work less than full time from ST1, how does the duration of the training pathway change?
I think it depends on the percentage. So if you've gone 50%, it's literally double. So if it's 7 years, then it's 14 years. But if it's, I think 80%, it adds 3 months to every year, from what I understand.
Yeah.
So, and it depends on, I think, so you can do it from ST1, then you just calculate 3 months by 7 years and see how much that's gonna add on. And the good thing about going less than full time is also you can literally change if you want to do 80%, ST3, you feel like actually I want to bump my hours a bit more, go 100%. If you decide, oops, actually it's a bit too difficult, let me go down to 70%. They're very flexible and accommodating in that regard. But it like the person asked, it would add depending on, because I'm full time at the moment, but I know people who are 80%, and I think it adds 3 months, and I know someone who's 50%, so it's gonna add another year.
Yeah.
And also, like exactly what Nadira said, it's not a unilateral decision. You can change your mind. So you can drop down 60, jump back up to 80, jump back to 100. So it isn't like a fixed decision. You can change it, but you do need to give the deanery notice. Our deanery says you need to give 3 month notice. Okay, so the next question here I got is for each of you, what was the pivotal moment that inspired you to do obstetrics and gynecology?
Oh. I think so, like Nadira, I liked pediatrics when I was a medical student, but then I went to Somalia and things changed. Um, I think when I went to Somalia, I just thought it was really interesting, the women who would come to clinic and the way they were so like they would never go to antenatal clinic, or they would never go to like they would never listen to the doctors, and they would always be crazy deliveries. Like it would be so interesting when you came, like you would see abruptions, you would see like placental previas and things like that, undiagnosed cases, the rare cases in labor wards. So that's what made me really interested in obstetrics and gynecology. And then I heard the story about Dr. Hawa Abdiallah Naharistu, who passed away. She was an amazing obs and gynae a consultant in Somalia. She had a Nobel Peace Prize. She was a Nobel Peace Prize nominee. So she was really interesting. I thought, okay, I want to be like her. So that's what made me kind of get into it, the specialty and the high maternal mortality rate in Somalia. I thought I could, try to make a change when I finish training to go back and see what can be done there. Yeah.
I think for me, like Ladan said, I was like gung-ho about pediatrics when I got into training, even up until the last minute where I was accepting between,
Yeah.
I had both offers. But I think for me, I actually ended up falling in love with obs and gynae when I did an elective in Kenya. And I think it was just the fast pace of it, the fact that, you know, no two cases were the same. I think also when you are doing it in a place like Kenya, for example, you just genuinely see, you know, how the lack of resources. I've never gone to Somalia, but I could just imagine how it might be. And I just thought to myself, you know, this is something that is very hands-on that I could do. And it gives me the balance because I do like a bit of medicine as well. So it gives me the balance of medicine and surgery. Whereas I was like, oh, if I do peds, it's basically internal medicine for kids. But not that I'm, you know, making talking about peds in a negative way, because I still feel like sometimes I'm like, oh my God, I see neonates.
Yeah.
I'm like, oh, maybe I should have, but no, I do like obstetrics. But I think it's also a very rewarding career, and also I think it's something that is very needed anywhere you go in the world, especially Somalia. So I thought to myself, it's something that I know the skill set that I get, that inshallah I can hopefully use it to kind of improve you know, the situation back home if possible.
Amazing. Inshallah. Well, I'm going to ask you three more questions, guys. Okay, so the next question is, what is your advice for somebody who's interested in the gynae aspect, but not in the obstetrics aspect?
We were just talking about that. You
Yeah. Yeah, we were talking about that before the presentation. Yeah, there are people who a lot mostly not even just a guy thing. Some guys not interested in obstetric, they want to do the gynecology, like the gynae-onc, which is really cool, and urogynae, which is like really popular nowadays, like a plastic surgery type of field. So for them, they just have to get through the 7 years, and then they can, because we have consultants that don't even come to labor ward at all. If there's an emergency going on labor ward and we need another consultant to come in and they're called, they're like, oh, I don't remember obstetrics, who just kind of deal with their own gynae. So yeah, you don't have to do labor ward, but you have to do the 7 years training, and then the odd case once in a blue moon they'll call you to come and help out, but
I
that's
think
about it.
towards the end, like you said, like you have to do the obstetrics aspect in training. I think towards ST6, ST7, some people, it's very competitive, but if you get into like sub-spec training, like gynae-onc or urogynae, like Ladan said, maybe then you can kind of reel down the obstetrics aspect of it. But you also need to think long-term, because I think it's also when you're a consultant, being a generalist is actually a positive in terms of if like for jobs and stuff, they always need obstetrics. Gynae, they still need gynae, but I don't think they would need as much gynae as they would need obstetricians. So you have to also think about what you want in the future as well.
Yeah.
So another question is from somebody who's a medical student, and they want to ask, as a medical student, what things can I do to prepare myself for a career in obstetrics and gynecology?
Okay, so doing audits, research, they love research. You can always go to the obstetrics, the obs and gynae department, and kind of ask their research lead or their audit lead if you can kind of help out. And I've seen a few medical students who do posters, who have competitive posters, who go to conferences. So that's really good. It's good for your CV and your interview portion of the application. So yeah, you can always do that as a medical student.
And then if you're doing F2 or
Okay,
F1, try to get like obs and gynae rotation if possible, so that you can
Yeah.
have more, exposure to it as well. Because it's
for
also
sure.
good to have the exposure to see if you even like it when you start working in it.
Yeah. Mhm.
Definitely. And what I would also say is just for whoever asked that question, make sure you join the final session of the series, which is specifically geared at medical students how to get a portfolio ready, because there is so much that you can do. For example, each like society, so for example, there'll be like an obstetrics and gynecology society, they will always have a medical student representative role for a regional or a national position that you can join. There's audits, like Lada said, QI projects. There are so many like assistantships, exchange programs. Like I did an exchange program in oncology. I've got nothing to do with oncology today, but there's so many opportunities available for medical students. But we'll go through all of that in the final session, inshallah. Okay. And then the last question is, somebody has completed the MRCOG part 1 and part 2. So they've asked, how do they're an IMG, so how can they kind of get their registration? aspect? Will they be joining at ST3? Like, how does any of either of you guys know how that works? Because you guys started from ST1.
So do they want
Yeah.
GMC registration or do they want to, because it
The
depends.
question said GMC registration specifically.
So with GMC, you have to do full MRCOG. So you have to do
Okay.
the part 3 as well.
Okay.
And once you do the part 3, then you can apply for GMC registration that way, and then you don't have to do PLAB.
Okay.
Yeah.
Great. So that is excellent. Thank you so much. And let me just make sure that I haven't missed any other burning questions. Okay, I'm going to ask you guys one more question. One last question. What would you say would be the challenges that you both have? Okay, yeah. What would be the challenges that are faced by IMG doctors that are working in obstetrics and gynecology, specifically from an IMG experience?
Yeah, not understanding your role, I think, in the beginning, kind of, because there's so many, like there's midwives and the doctors, and a lot of the doctors, they know how to do, like, for example, discharge letters, prescribing, all of that. And I think coming as an IMG, it's difficult to get around the non-technical part of everything, because they've been going towards since they were medical students. But us as IMGs, we haven't had that experience in the UK. So it is kind of hard, in the beginning, getting around to that, like how they do ward rounds and the note taking and all of that. That was a bit tricky for me in the beginning, but you get used to it as you go along.
Yeah, I would say the same thing. Obviously doing a non-training job for me as like a trust grade doctor, that kind of really helped me, so that by the time I did get into training, that's not something I struggled with. But when you're basically it's the NHS system, if you're an IMG, it would be hard initially when you're trying to wrap your head around things, and then still having they're still expected to, you know, perform as with everything else, but what is a respect form? What is a sepsis bundle? Like, you know, it's the non-technical things, like Lovin said. But I think with training, it's still very supportive, but I think you would kind of be expected to at least know those things, but you can learn from people around you. It's not something that should kind of still hinder you. That makes sense. I got through it. Trust me, somebody knows I was struggling when I started, so alhamdulillah.
Alhamdulillah, alhamdulillah. Okay, amazing. Okay, thank you everybody for joining the webinar. It is great that you've joined us to further your career. Firstly, I want to say thank you so much to our presenters, Dr. Laden and Dr. Nadira, for giving their time to share their knowledge. For everybody that's attended, there's two things that I always ask. One is please, please, please fill out the feedback form. It's helpful for the presenters, and it's also helpful for me to work out what can be improved. The second thing I always say is that in the future, I wish for you to pay this forward. Essentially, we're trying to build a strong community, inshallah, especially as most of us are first generation healthcare professionals. Particularly for me, obstetrics and gynecology is a very, very special speciality. I get to have the privilege of working with Nadira in the same hospital. So often after a heavy surgical list, she'll be coming to me in my radiology room. And I'm always in awe. I'm always in awe. Honestly, after she finishes a very heavy surgical list, she'll come to me in my on-call room. And one thing I can say is I'm thankful not to be in her shoes. And secondly, I can say is that one thing about Dr. Laden and Dr. Nadira is that their passion for their field emanates. So may Allah subhanahu wa ta'ala make Laden and Nadira's scale heavily tilted with good deeds. I think to be able to welcome life, to honor women and to help them shoulder difficulties is a very, very special job. So yeah, thank you very much, everybody.
Thank you guys for joining.
Please fill out the feedback form. I will wait for 5 minutes until people can copy and paste the feedback form. Nadira, you can stop screening it. You're still sharing. Yeah, you are.
I'm going to stop to share. All right, Jazakallah khair, everybody.
Amazing. That was a very, very good presentation. Really enjoyed it. There's a few more people. Please copy and paste.
Oh, and we're happy for you guys to contact us. I left my details.
You left your details, haven't you? Okay, on the last slide. I'll share it amongst people if they can email you guys.
Okay, inshallah. I'm gonna be leaving. Thank you guys. Assalamu alaikum. Thank you a
Salam
lot.
alaikum, Ramadan. Salam
See you
Thank
when
you.
I see you. Assalamu alaikum.
See you at work. Salam alaikum. I'll just wait for everybody else just to copy and paste the link. And thank you for joining. Just repost the link in case you haven't got it. Okay, Assalamu alaikum, everyone.